Hello, folks. How are we all doing? Welcome, welcome. And we enjoy seeing you this lovely Wednesday. I always know my East Coast fam, Steven, you are on the East Coast, so it's not really noon. My day's just starting over here, but welcome, everyone. It's great to see you all. So my name's Chris Trondsen. I'm a licensed therapist who treats OCD, BDD, and related disorders. I also have OCD and BDD and dealt with numerous diagnoses. So I'm just here clinically answering your questions as well from live experience. And I can't do this alone. So I have a guest today, which I'll talk about in a second. But if you're joining us every Wednesday here at 12 noon Eastern, we have live streams with clinicians. We'll have psychiatrists on. We'll have experts in specific subtypes or fields. We've had people come on talking about the correlation between OCD and autism, OCD and ADHD, skin picking, hair pulling, etc. We also have other experts come on and just talk about OCD, answer your questions. So this is really a stream for you to get education, to ask questions, to interact with other people in the community. So you're watching this on some kind of stream. It could be maybe Twitch, maybe it's X, maybe it's Facebook, it could be YouTube. You might be watching it on the IOCDF.org/live, but there's a place to ask questions. So submit questions. Stephen and I, my special guests, are going to talk 15, 20 minutes just about the general world of medications and psychopharmacological interventions. And then we're going to open it up to some pre-submitted questions that we were sent about the topic, as well as your questions live. So as always, this is your stream too. Please interact. It's always good to see all of you. Introduce where you're from, your name, what brings you here, who you're supporting. Are you a clinician? Are you a person with OCD? Are you a sister, a brother, a parent of somebody with the condition? Let us know what brings you out to the stream. And then, like I said, ask your questions. We'll answer as many as we can in the order that we receive them. So before I introduce my special guest, just a couple quick announcements. As always, this is a live stream, but it's not intended to replace an emergency situation or therapy. So please, if you're really struggling right now to the point that you need help, you can dial 988 or go to 988lifeline.org. You can also go to iocdf.org/find-help, as you see on the screen, to find a trained clinician that can work with you. You can go to an emergency room or call 911. But remember, we're here to support, to help, to give advice, but we can't replace suicidal intervention or some other emergency situation. Also, this is going to be streaming live. Be kind to each other, and this is going to be up for rewatch. You could watch it under Facebook, IOCDF's Facebook under videos, or their YouTube under live. All right. Well, I'm excited to have my special guest. So, Steven, do you like Dr. Poskar? Do you like Steven? Do you like Stevie?
Steve is fine.
Like Steve from the Bronx? No, I'm just kidding.
Steve is absolutely fine.
Well, Steven, real quick, where did you say Steve or Steven?
Steve, either one.
I'm going to say Steven. I like Steven. Where in New York are you located? Your office?
So my office is on 38th between 1st and 2nd.
Which means nothing to somebody from California. What borough?
So it's in Manhattan, and it's in a little area called Murray Hill. So I'm in New York City, in Manhattan, in Murray Hill. So kind of, again, it's on 38th, right between 1st and 2nd Avenue.
Awesome. Well, it's always good. Bi-coastal here, representing West Coast, East Coast. So, Steven, I'm really excited to have you on, because obviously I've worked, we've been on streams together. And I always just get feedback from everyone that you're super concise. You answer the questions the way that people can understand it. But this is not new game. You've been doing this for a while. So why don't you introduce yourself? Tell us a little bit about your practice, and then just overall your passions and your interest in this field.
So again, my name is Steve Poskar. I am a psychiatrist and specializing in OCD and related disorders. So a lot of OCD, BDD, body-focused repetitive behaviors, hoarding, but also, again, because of the comorbidities, a lot of autism spectrum disorders, we see it, I see regularly. I've been doing this for about close to 20 years now. And, about 15 years, I've been on the scientific advisory board of the IOCDF. And right now, actually, myself and one of our great psychologists, Dr. Jonathan Abramowitz, we are actually currently working on the IOCDF's treatment guidelines. So I'm doing the ones for pharmacology, and Dr. Abramowitz will be doing all the psychosocial therapies. Because, again, we're trying to get people, especially in the IOCDF, to be able to go somewhere where they can really look at a kind of treatment recommendations and things like that. So, currently that's the project I'm working on. I'm one of the few psychiatrists, I think, in the field that kind of does therapy. And so, I tend to do therapy on a lot of cases where they've kind of failed other treatments. And really, that's kind of the nature of my practice. The nature of my practice is, I rarely get people, although I love to, get new people that say, I have OCD, I think, and never been on any medication. But for the most part, probably 80% of the people I see are people that have been to 4 psychiatrists, that have been on 17 different drugs, and nothing's working. And that's really kind of the cases that I tend to see the most of. And again, that's kind of my main practice is really seeing refractory patients, or seemingly refractory patients. As I'm sure we'll talk about, there are some people that think they're refractory. They're not refractory. They just have never had the right treatment. And again, it's there's not a lot of us that do this in this field. And so, again, I think educating people through the IOCDF is a big thing for me. Being part of the IOCDF has been a huge, huge thing for me. And I think the educational component, not just for patients, but also, working on educating psychiatrists, psychologists, so people have more access to care, because I think that's a passion thing I'm really passionate about, because again, it's, really, it's hard when you see patients that have been in the world of treatment for 10, 15 years, and they haven't been seeing people that really understand this disorder. So making sure that, again, as part of the IOCDF, we're doing stuff like this to really help, again, educate both kind of patients, families, but also professionals.
Well said. If you're just joining us, that is Dr. Stephen Poskar. He is joining us today for the live stream. Make sure you ask your questions. As you heard, Dr. Poskar also does therapy like myself. So if your question isn't medication specific, that's okay. Usually I'll answer them, but actually it's great to have a guest that can answer them too, as well as medications and other interventions. So please, please, please get your questions in. I do have a lot of pre-submitted, but I also always make sure we get to live. So before we jump into questions, I'm going to ask some questions that I constantly hear from clients, because I think they come to us a lot of times with some intimidation to really open up to a psychiatrist. And I'm going to kind of ask the questions that a lot of people are here, asking. And I would start, the first one that I get asked a lot is somebody starting therapy with me, and they're asking me, should I get on medication? What are the success rates if I get on medication? Will I get better in treatment if I'm on medication? So there's a lot of times where people are kind of trying to figure out, like, is dedicated OCD therapy enough? Does it need to be medication, et cetera? So for you, what's that litmus test? How do you know, like, hey, I think this person will really benefit with medication or some other psychopharmacological intervention? What is kind of that like litmus test for someone that maybe they need to have an additional component besides just therapy treatment?
It's a great question. So one thing I always clarify with patients is there are people with OCD, as well as other kind of OCD and related disorders, that do well and get better on getting good therapy alone, exposure response prevention. There are people that never do medicine and they do fantastic. There are very few where the opposite is true. It's very rare for someone to just be on medicine and to kind of get better from that, right? And partially that's because if they're not learning how to not reinforce things, it's kind of, they're almost fighting themselves. The medicine's pulling one way, but they're kind of not educated on what they're supposed to be doing. So, there are a lot of people that start on just therapy alone. And so one indicator is sometimes I will get a call from a therapist that will say, hey, I've been working with this person, and it's just, they can't even hear what I'm saying. The volume of the OCD is just so high for them that we can't even kind of get any movement. And we've been trying for a month, 2 months, 3 months. And we're hitting a wall. So that's one time where we say, okay, do we want to kind of give medicine a try? Other times people come to see me, they've never had any treatment, and we talk about it. And there are some people where their OCD is at a level where I think it's unlikely that they're going to be able to get by on therapy alone, or that I don't think they're going to be able to engage in therapy without some more help. And again, I always tell people, medicine is not something you are signing up for life, right? It's not surgery. It's not something we can't undo. And so there are times where we start people on medicine, they do well in therapy, and then we can slowly pull the medicine back. Other people just do better on the combination. But I think that, again, the question has no clear answer, right? There is no clear litmus test of where it is. I also think it's a lot about patient preference, right? That, that some patients will say, like, look, I know my OCD is pretty bad, but I'd love to try to see if I can do therapy alone. And we say, okay, let's give it a trial. There are other people that come in and say, anything that can help my OCD right now, I want to do everything I can. And so, but again, I think a lot of times for more mild or even moderate cases, therapy alone can work. I think the more severe it gets is the more likely that we're going to kind of need both interventions. But again, there are people, again, that do therapy alone. There's very rarely that people do well on medicine alone.
Okay, well said. The other question that I get is about how quickly it works. I want to kind of go through the classes that I've heard, clients come in. And so I know some clients might get, frontline is often an SSRI. So that we're talking Prozac, Luvox, Lexapro, et cetera. I know patience is key. Patience is a virtue. So if somebody's watching this and they're contemplating starting medication, or they're on medication, what should be like, hey, I've been on it for this long, I should start to really see the medication work? What would that look like? What does it mean that it's working? But what is kind of that timeline for an SSRI? And I'm going to go through a couple different classes, but let's start there.
So it's a great question. So, excuse me. One of the things we talk about when we say, like, how long does it take an SSRI to work? I think the important thing, especially with OCD, is to say, well, how long will it take it to work once we get to a dose that it will work for you? Right. So, if somebody, we'll talk more about this, but, if somebody is going to end up responding to, let's say, 60 or 80 milligrams of Prozac, usually when I get people to a dose that is going to work for them, I usually see something within 4 weeks. Not everything, but that there's some improvement. And if I see improvement in a month, I often go, okay, let's give it another month, because often that will grow. But usually for trials, you want to give kind of, at least kind of, sometimes people talk about 6 to 8 weeks. Some people go a little bit shorter. But again, that's also once you get to the right dose. So when we say, well, people start medicine, when am I going to start feeling better? At the lower doses, you might start noticing an improvement in mood and anxiety. And, but then eventually we get to the dose that you're going to end up at. So I think that's just something to remember, that when we say, oh, it takes this long to work, it takes this long to work for the dose that ends up working for you. But there often is a build, and depending on how severe somebody is, we might go pretty quickly up. Sometimes we go a little bit slower. But again, usually within 4 to 6 weeks, you'd like to see some movement. Again, not everything. And one of the things we know is that, again, that often when people get a response, that response will build month over month over month.
Yeah. And I always tell people, like, for me personally, when I went on medication, I just started to notice that every day it was sort of like someone turned down the volume of the OCD. My brain got a little bit quieter. It was easier to focus. I wasn't distracted from intrusive thoughts. And overall, it just felt easier to push through and do treatment. I tried the first 6 months without medication. But when I got on medication, it just sort of became cohesive with the treatment. Let's say someone gets prescribed more of like an anti-anxiety medication. Boost Bar is the first one that comes to my mind. I know sometimes clients might get diagnosed that in conjunction with an SSRI. Sometimes people are getting it solo. I'm not saying it's always right, so that's more for you to tell me if that's right. I'm just talking about what I see in my office. Can an anti-anxiety medicine like that help, like a Boost Bar? Should it be added on, and about how long does that take to work to see signs?
Well, I think we should kind of, when we say anti-anxiety medicine, right, we're really not talking about a class, right? We're talking about a bunch of different classes, right? So buspirone is kind of in its own category, right? It's this, what's called kind of a serotonin 1A partial agonist. We use that for anxiety. We use benzodiazepines for anxiety, things like Klonopin, Ativan, Valium, which are very different from something like buspirone sometimes. And again, they're really always to remember the number one anti-anxiety treatment that we use for all anxiety disorders are SSRIs, right, that we use. So buspirone, again, buspirone can be helpful for people with anxiety. When we're treating OCD, one of the things we have seen is that when people are on an SSRI and it's not working, despite the fact that we get to a decent dose, that when you augment with buspirone, people can actually improve. So buspar is an augmentation kind of treatment that we use. One of the reasons buspirone fails is because people don't dose it high enough. And so, a lot of people early on thought buspar wasn't a very good drug because it didn't work as well. And that's because a lot of people were giving people 15 milligrams twice a day, so about 30 milligrams. When we use it for OCD, usually you want to get to about 60 to 90 milligrams. And again, as an augmenting agent, it's a decent, augmenting agent. What it looks like from research is people that have a partial response to SSRIs are more likely to improve with buspar than people that are having no response and then you add buspar. It doesn't seem to work quite as well. But buspar is, again, a nice drug also just from balancing efficacy and side effects, right? Buspar is really low side effect drug. And that's also part of the equation is what's going to work, but also what's going to be tolerated.
Yeah. I put in the chat for Emilio to throw up, but I know there's a good post on the IOCDF website. You're doing an updated one. Cannot wait for that. I'm so excited because it helps us clinicians, right? Like I send a lot of people this IOCDF by Dr. Janicki article about medications because what you're saying is that's a big thing that I have. I'll have clients come in and maybe they're on a half dose or a quarter dose from the typical OCD medication dose. And I'll look at the research and I'll look at the articles and I'm like, wait a second, Prozac, they're saying 80 milligrams. Yeah, I have a client that's been on 20 milligrams for 5 years and not, thinking that that's the best it's going to get. So why that's why I always push a specialist who knows OCD. So why is it important to find someone who specializes on it, specifically about which medications to use as well as the dosage?
So I think, again, the main frontline treatment for OCD from a pharmacology standpoint are SSRIs. And, or I should sometimes we should say serotonin reuptake inhibitors, right? And typically we start with SSRIs. There's another serotonin reuptake inhibitor that we use, one of the older tricyclic medicines called clomipramine. We usually don't use that first line because it has more side effects, but we often use it when people aren't responding to SSRIs. One of the problems we see, and I know you know this really well, is that the dosages that we use of SSRIs for anxiety disorders and depression is much lower than what we use for OCD. And so the problem sometimes happens is somebody comes into your office and says, I've been on Prozac, it didn't work. I've been on Zoloft and it didn't work. Until I know what dosage and for how long, I don't know that it doesn't work, right? Like you said, if somebody says, I've been on Prozac 20 milligrams for 2 years and then they moved me to 40 and it never really helped me. So then we switched to Zoloft and then whatever. Well, I have to say is you never really had a trial of Prozac. Right? Because until I'm getting it between 60 and 100 milligrams, and so that's just one of the big issues. And I think some non-specialists aren't comfortable pushing SSRIs just because they haven't done it a lot. And one thing I think maybe we should clear up here, because it's connected to this, is the worry about serotonin syndrome, right? And so I think some clinicians worry about it. Patients will sometimes ask about it. You don't tend to see serotonin syndrome when somebody's just on an SSRI, even when the dose is really high. Serotonin syndrome usually happens from a combination of drugs, but I think, again, it's something that clinicians, again, they get uncomfortable with. And I think really good clinicians will often say, hey, this isn't my area. Let me send you to someone that really specializes in this. So I think that's, one of the big things is, again, we always have to know what your dosage is and for how long you were on it to really judge if it was an actual trial. And as you know, so many people come in, they've been on 3 SSRIs, but none of them have been on real trials. And that's where I think when we started talking about, they think they're refractory to treatment because they're like, I've been on 3 SSRIs. I'm a refractory patient. They're not. And then suddenly you push one up and they do great. So that's kind of like one of the big issues we face.
You had mentioned it earlier, benzodiazepines. Can you talk a little bit about that? Is it helpful for OCD? When does it come into play? So we're talking about the Ativan, the Klonopins, the Xanax. I hear that all the time. So just kind of checking in on that. What's sort of the field saying about benzodiazepines for OCD?
So, and especially for you, and everybody as a therapist, this is a very commonly discussed issue, right? And so, benzodiazepines, can be helpful for anxiety. And the question is whether you're giving them as needed versus as you're giving people a regular dosage certain times of the day. I think that's a big factor, right? Because one of the things we worry about doing therapy and things like that is if we have somebody in therapy, right? And part of what we're teaching them is tolerance of anxiety, tolerance of discomfort, that anxiety isn't dangerous, right? And to do that, we make sure they don't do compulsions because the compulsions reinforce that the anxiety is a huge problem and they can't tolerate it. Well, if we instead, when somebody gets really anxious and their OCD really amps up, if we give them an Ativan to calm them down in the moment, we're kind of giving the same message. And so you want to make sure that if you are using benzos, that you're not using them to kind of get rid of that immediate kind of momentary anxiety. I would say that, there's no evidence that benzodiazepines do anything to treat OCD, right? So OCD is always remembering the primary symptom of OCD is obsessions and compulsions, right? People can have anxiety and often do with OCD, although as you know, some people don't have anxiety. Some people have disgust. Some people have guilt. Some people have a not right feeling. And so for the primary symptoms of OCD, the benzodiazepines don't do anything. I, don't use a lot. Sometimes when people are at a really bad period of high anxiety, I might give them a benzo for a short term. But again, even then, I like to give it like twice a day on a regular schedule so that they're taking it in the morning and then again before bed. It's not something they're popping in the moment that anxiety comes. Because again, I think we're kind of doing the opposite of what we're trying to teach them in therapy.
One of the things that also clients will ask about is they'll get prescribed they'll have their SSRI, but maybe they'll get prescribed as well as like Abilify, for instance. And then they find out that Abilify is in a class, antipsychotics, and people get very, very anxious about that. So in OCD, when would we use kind of a medication like that? What is its purpose? What should clients hear about this? Because I think there's a lot of fear.
Yeah, so I think one thing is this class thing, and I wish kind of somehow this would get changed. So there are classes of drugs, right? So again, like going back to SSRIs are selective serotonin reuptake inhibitors. That's their class. But we often just call them antidepressants, right? Because often they get a kind of common name for whatever we use for them first, right? So even though we call, right, and I'm sure you've experienced this, where people go, why am I on an antidepressant? I'm not depressed. Mm-hmm. Well, you're on an SSRI because they don't just treat depression, they treat anxiety and OCD. The same thing with antipsychotics. So antipsychotics, right, are classically kind of drugs that block dopamine and often like dopamine 2 receptors. And originally, one of the first things we used them for was psychotic disorders. And so people give them the common name antipsychotics. But we use them for so many other things, right? So they are used for augmentation not only in OCD, but we use them in augmentation in depression. We use them in bipolar disorder. And so again, I think people get scared off in the same thing, right? Which I'm sure they said to you was like, somebody puts them on one and they go, wait, do they think I have schizophrenia? Why am I on an antipsychotic, right? And especially people with OCD can get very worried about stuff like that. And so, the use of kind of, dopamine blockers, antipsychotics and OCD, what we know from research is about a third of people, if they don't respond to an SSRI alone, if you add a low dose of an antipsychotic, about 1/3 of the people will respond to it. And, so, there's kind of, again, there's a number of antipsychotics. We probably have the most evidence for the antipsychotics like Abilify and risperidone, more so than others. I think, the dosages also that we use for OCD when we augment with them is not the same dose as we use when we're treating schizophrenia or bipolar disorder. We use much, in this case, we talked about higher doses of SSRIs for some things. We tend to use lower doses of antipsychotics. when we treat stuff like this. One thing I always like to clarify with people is antipsychotics don't work any better for people with low insight, right? People with low insight OCD are not psychotic, right? And so I think sometimes people think, oh, well, they're kind of delusional, right? Because they have a belief that doesn't make sense and they have very low insight. Let's give them an antipsychotic, because that's like, the evidence doesn't show that. They don't work any better for somebody that has less insight, that has more insight, or anything like that. The other big thing I just always mention is, one of my kind of pet issues in the field is I think people give these out very quickly. And I think people give them out and assume because they're using a low dose that there aren't side effects. And, anybody just, who's on an antipsychotic, there are certain rules that we have to follow. Before you start an antipsychotic, you get somebody's cholesterol, their fasting blood sugar, you get their weight. Why? Because antipsychotics can cause what's called metabolic syndrome, where people get increased cholesterol, insulin resistance, and prediabetes, weight gain. And so before you start an antipsychotic, you have to measure those things, and then you measure those things after 3 months, and then you measure them every year after that. The number of patients that come to me on antipsychotics that have never had lab work is mind-boggling. And I think sometimes because people think, well, I'm using a low dose, it's not a big deal. So these are good drugs, but they're not drugs that should be given out without letting patients know. And again, this is the other part that, psychiatrists don't often do, is sometimes they don't psychoeducate them. Like, here's the drug, but there's a risk of metabolic syndrome. There's a risk of tardive dyskinesia or movement issues. And so, again, they're probably our biggest evidence-based augmentation treatment for OCD, but it's not necessarily the one we use first because of the side effect profile.
I like what you said there a second ago. I mean, I think shout out to Dr. Jamie Fusner, who I know a lot of people know. That was my psychiatrist. And one of the things that was really different from him, I couldn't even tell you the name of my other psychiatrist, the first one that I saw, but it was such a horrid experience. I mean, it was literally like 15 minutes. I was petrified to go on medications because of OCD. My brain made up a whole bunch of reasons why medications were dangerous. And I'm like nervous. I go in this appointment. The guy spends 15 minutes or less with me, throws the medication at me, is on my way. And I'm just like, what? And I remember working with Dr. Fuser. I mean, we sat there, the intake, he answered my questions, et cetera. And I think that's what's tough for a lot of people is that, there's fears. Some of them valid, some of them OCD created, but there's fear there. And there's not always good bedside manner sometimes where, and it's not only psychiatrists, it could be a PCP prescribing, it could be a nurse practitioner, et cetera. But I hope that sometimes if psychiatrists hear these conversations, they recognize that I know you guys know, right? Just like when a client is fearful about ERP and CBT and ACT and stuff, it's like, I know it's beautiful work. It's going to help them out so much. But I know that the client's coming in with no background. Just because I have the background doesn't mean they do. And there's a lot of fear. So, that's a thing I always tell people when they're looking for a psychiatrist as well, is find someone who you feel is listening to you and coaching you through these things. Now, obviously there gets to a point, you can't have, reassurance every session for hours and send emails and that stuff. But in general, getting your questions asked and feeling comfortable.
Well, and I think that's really important what you said. I think to me, when patients come to me and I ask them what they're on and why they're on it, and no one's ever explained it to them. Right. And so, it is important that patients feel completely comfortable to ask questions. Right. And I always tell them, ask me any question you want. There's no stupid question. And by the way, if you have a question that you're never going to offend me, you are allowed to challenge what I say. This got to be the relationship. Right. If that's not the relationship, then things aren't going to happen. I think another important thing, you asked before, what are the advantages of seeing a specialist? It's not just the pharmacology. It's right. I'm sure experience this all the time. The number of people with OCD that go see a psychiatrist who starts them on meds, and that's the first person they see, and he never mentions therapy to them, right, is huge. And part of our job, and I think part of every psychiatrist, psychologist job is when somebody comes in with a disorder, it's our job to tell them what the treatments are, not just what the treatment we do is. Because there are lots of people that have been on medicine and see a psychiatrist and have never seen a therapist. And the psychiatrist has never let them know that there's something called exposure and response prevention. And again, we really want to make sure that patients are really educated and they feel really comfortable. I think the only thing I would address is I think what you said was great, which was people sometimes don't want to be on medicine because they're worried about certain things. My big thing is I never want someone not to be on medicine because they have a fear that is unwarranted, right? And so people will come in and say, I don't want to be on medicine. I say, why? They say, I'm worried about, kidney damage. And I'm like, well, there are many reasons one wouldn't want to be on medicine, but SSRIs don't cause kidney damage, right? So making sure that people are making informed decisions, that they're not kind of not being on medicine for reasons that are unwarranted.
Yeah, well, I think that's why, I totally understand like not asking hours and hours of reassurance, but I think that was what's so helpful for me is because my brain made up a bunch of things like my contamination, right? If I touch my pill and put it in my mouth and it's not clean, could that infect me and get in my system? Could it cause brain death? I mean, there's all these things where your brain just makes up stuff. I had body dysmorphic disorder. My brain was like, does the medication cause acne? Does it make you look tired? Does it age you? Does it make your hair fall out? Does it make you gain weight? I mean, there's all these fears. People that have OCD and eating disorders, right? Eating and feeding disorders, they might think it makes them gain weight, and that's a big fear. And even if there are certain things, just having that conversation. But I love that you do that because unfortunately, I would say most of the time, sure, there's sometimes like sexual side effects and weight gain or weight loss or sleep. And those are kind of like where I'm like, hey, talk to your psychiatrist or prescriber. But there's so many like conspiracy theories or things that are just, whatever their specific OCD fear is, somehow it ties into medicine. So that's why I always say like, find someone that understands OCD. Because if you go to a prescriber and ask these questions, they're not going to know how to talk to you in a way that really helps you, navigate through the OCD.
I think something that, like you said, is one of the tough things is, I always sometimes say that there's nothing worse that happened for OCD than the internet. And part of the problem is if somebody's got a fear, right, and they say, I'm worried that SSRIs are going to damage my kidneys or, do this or that. If they Google the word SSRIs and kidneys, they will get like 100 posts of people saying that it does, right? And so that's, also really where we have to educate because people are doing, it's funny, sometimes my patients will say, oh, I did research. And I said, when you say research, do you just mean you Googled stuff? It seemed to equate. I said, well, that's not exactly research, and the information's not always accurate. And I think, that adds a level of complexity to kind of misinformation and stuff with the internet.
Yeah. I want to ask two quick questions, and then I'm going to get to some of the questions that we have submitted and live. The SNRIs, so something like a Prestique, when does those come into play? Because I've had clients on Prestique or other SNRIs. What is the advantage or disadvantage of using those? When do we use SNRIs?
Sure. So first, what's an SNRI? So, SSRIs are selective serotonin reuptake inhibitors. They kind of increase, they block kind of the reuptake of serotonin, increasing serotonin. SNRIs not only affect kind of serotonin reuptake, but also norepinephrine reuptake, also called noradrenaline. And there are multiple SNRIs, and the SNRIs are not all the same. And so there are some, if you look at like the original first SNRI we really used was a drug called Effexor or venlafaxine. That is still predominantly serotonergic and has a little norepinephrine reuptake, especially as you get higher. Then after that, you go to Cymbalta or duloxetine. That's got a little more norepinephrine compared to serotonin. And then when you go on to Prestique, the levels change. And so the only one we really have, we don't have great data on them. We probably have the most good data on Effexor. And so there are definitely people that respond to Effexor. It's never a first-line drug. The data is just not there. We have little information on duloxetine, not anything really on Prestique and other things. And so, sometimes people will try multiple SSRIs. They'll fail. They'll try people on something like venlafaxine or Effexor. I will do that occasionally. I have people that I've put on Cymbalta that have responded. But it's definitely not a first-line drug that people tend to use. And again, and so, it's one of those things where, again, we start with the SSRIs. If people fail multiple SSRIs, sometimes people will try an SNRI. And again, if someone's going to try an SNRI, I probably have the most faith that Effexor's probably, again, because it does the most kind of serotonin reuptake.
Well said. The last question I have is, I know sometimes people will take medications to help sleep because OCD impacts sleep. I've heard things like trazodone, Seroquel, and stuff. Since OCD seems to affect a lot of people's sleep, is medication a good thing to take? Should they just try melatonin? Like, what's usually the best thing to do?
So SSRIs can definitely affect sleep and really in multiple ways, right? So some people can get, difficulty falling asleep, difficulty staying asleep on SSRIs. Other people, right, especially as the doses get higher, get the reverse. They get really tired, right? And they're kind of get exhausted. And so there's multiple ways to go when you're treating sleep. One of the things I tend to do, right, that when it's SSRI-induced sleep issues, I will tend to use trazodone. And the reason I tend to use trazodone is because trazodone actually blocks the serotonin receptor that SSRIs are activating that seems to cause the problem. So it seems like it's more of a kind of elegant way to treat the problem, right? Because I'm kind of causing it, right? So when you give an SSRI, it increases serotonin. So it hits every receptor that has serotonin. There are receptors one is like the serotonin 2A receptor, which trazodone blocks. And we think 2A is where the sleep stuff comes in. So I will often use trazodone. Obviously, one of the issues, I said obviously, like it's obvious. One of the issues that you run into with trazodone sometimes is kind of, the next day people are a little tired. So they'll say, it helps me sleep. And sometimes that's a dosage thing and we can kind of adjust that. But for SSRI-induced sleep problems, I tend to kind of start with trazodone. We have other medicines that we use. Again, sometimes we'll give people low doses of a medicine that's used for depression and anxiety called Remeron or mirtazapine. And that can help people. Other times we will use kind of like the Ambiens and classes like that. Occasionally people will use benzodiazepines. If someone's using a benzodiazepine for sleep, I recommend they use Klonopin. Klonopin's the only one that doesn't affect what's called sleep architecture, right? So your sleep architecture is how much light stage sleep, how much deep stage sleep you get. The other benzodiazepines can actually, even though they can make you fall asleep, can affect the quality of your sleep. Klonopin doesn't seem to really affect that. So if I am going to use a benzo, and sometimes the reason I'll use a benzo for people is, as you probably know, patients have an issue falling asleep, but then that also builds into this issue of the anxiety about falling asleep. And it's interesting, right? I'm sure you've dealt with this. There are a lot of OCD patients who get very obsessive about sleep, right? If I don't get enough sleep, I'm not going to be able to do this. If I don't that. And so giving a benzo not only helps with the sleep, but it helps with that pre-sleep anxiety. So often I'll give it because I'll give a Klonopin an hour before bed. So they're already starting to calm down. They're not as worried and things like that.
Well said. We have a question from Molly Duran at 1211 who says, hello, I'm a therapist and wanted to ask about comorbid bipolar and OCD, how to navigate someone who goes into manic episodes on an SSRI and keep trying meds that aren't working to manage OCD and bipolar disorder.
So this is probably one of the hardest issues in OCD treatment, when people have both OCD and bipolar disorder. And why is that? Because the treatments are almost contradictory. Right? That the treatment for OCD tend to be high-dose SSRIs. The concern that people have with bipolar disorder is that SSRIs can kind of push people into mania or a manic episode. There's a lot of controversy in this area, right? There are some people who believe that people with bipolar disorder should never be on an SSRI. And some of that is based on research that shows that even if the SSRI doesn't flip them into a manic episode, that over time, if you look at them and follow them for years, they tend to have more manic episodes and more mood destabilization if they're on an SSRI. There are other people that believe if you put people on a strong mood stabilizer, often we use things like Depakote and lithium and things like that, that you can kind of safely give them an SSRI to treat their OCD. And so there's no real answer to that. I think sometimes it's worth a trial, but really the first thing in a bipolar disorder, you have to get them on a mood stabilizer, right? That's the first thing you do. Then you can try an SSRI and see. Other times for me, and this is kind of, again, where this, we don't have a lot of data on this. There are augmentation treatments we use for OCD that we have more data on adding them to an SSRI, but mechanistically, there's no reason to think they might not work on their own, even though we don't have research. So I will sometimes take someone with bipolar disorder, treat their bipolar disorder with mood stabilizers, and try them on one of our augmenting agents, like one that I've used a lot is Riluzole. And I will give them Riluzole, and I've seen some people respond. And so I will try that. But again, really, there's no easy answers to the bipolar OCD question with medicine. And again, sometimes it's just, and the big thing with bipolar patients is you got to monitor them, really, really carefully.
There was two questions specifically about exercise. So I'll use, not that one was better or not, but Matthew Bannister's was the recent one. So 1239, can exercise help with side effects for SSRIs with sleep? And then there's a question earlier, is there any specific exercise that's better or not to help managing anxiety for OCD?
So I don't think there's much data that there's one form of exercise. My big thing with exercise in general with patients is I always tell them, I think you should pick a form of exercise that you don't hate, because you're more likely to do it. And so, a lot of people, they go and they run on a treadmill and then they quit because they hate running on the treadmill, or they go to the gym and they hate, and then they quit. Okay, well, do you like sports? Is it better for you to play basketball twice a week or tennis, right? Because that's something you actually enjoy. Anytime we know that anything exercise-wise can improve mood, it increases endorphins. I don't know that we particularly have this strong anti-OCD effect. But I think, of course, one of the things is when you exercise, often people sleep better, right? You're getting a lot of energy out. And again, especially nervous energy. So people find that can be helpful. But again, I don't think I think, for some people, they love yoga. Great. Some people, they like to run. Great. To me, the form of exercise doesn't really matter. I want you to do some exercise.
Isastasia asked at 1231, Dr. Postgar, can you talk about hyponatremia or low sodium in blood while on Zoloft? My eating schedule is sometimes so bad and I'm nervous about it.
Sure. So hyponatremia. So what is hyponatremia? Hyponatremia means low sodium. And so your sodium levels are going low, right? So on a blood test, we can see that you have low levels of sodium, which can be problematic. You see it occasionally with SSRIs. You don't see it a huge amount, right? And one reason you don't see it a huge amount is because if we saw a ton of it, we would regularly be getting blood work on people on SSRIs. But it is something that happens occasionally. And I think the big thing is you want to test for it. And then part of that's also, I think, talking to a psychiatrist or your primary, right? And so sometimes you might want to switch a medicine. If again, I think I don't want people guessing that they have hyponatremia, right? You either do or you don't. So you get blood work. If somebody has hyponatremia, you'll often try switching to a different SSRI. But other times, again, in general, when people have hyponatremia for different reasons, again, sometimes their doctor will tell them you need to drink more sodium, right? You need to take more electrolytes and things like that. But again, if someone's hyponatremic with that I see on an SSRI, I'm usually going to stop it. First, I'll probably stop it and just see if it resolves. I want to make sure that they are actually, one is causative, right? Because that's also something to remember, right? If somebody's on Zoloft, they're hyponatremic, I don't know whether they were always hyponatremic. So the first thing I want to do before starting a new medicine is I want to stop the medicine, see if the hyponatremia resolves, and then start a new SSRI and get sodium levels and see.
Well said. So Sunny Meadow asks at 1227, is gabapentin ever used in treatment?
Sure. So gabapentin is a drug, right, that kind of has been used for multiple things, right? It was originally kind of an anti-seizure medicine. We also use gabapentin for neuropathic pain, right? We also sometimes use it for anxiety, and we sometimes use it for sleep. So there's no real evidence for gabapentin treating, again, the primary symptoms of OCD. Some people will use it if somebody's got OCD and they've got like a lot of anxiety. They might add kind of gabapentin to treat the anxiety, but it's not really treating the OCD. And again, sometimes we use gabapentin for sleep when people are getting side effects to an SSRI or just having sleep issues in general.
This question is good for my people taking OCD and a stimulant. Spence Robert asks at 1226, could somebody with OCD taking Adderall attribute that kind of like keyed up feeling? I'm guessing it's kind of like that zoned in and like antsy feeling to the drug rather than anxiety. Could this be beneficial? So does that happen sometimes where people are feeling more kind of like anxious or other sensations on Adderall and other?
So I think one thing is, this is the one reason that you always really try one thing at a time, right? So if I put somebody, let's say, on an SSRI, and then I add Adderall and they're more keyed up or anxious now, I kind of know it's the Adderall, right? And sometimes you don't know. Sometimes people have been on both drugs for a while and they don't know what's anxiety or what's Adderall. So we might stop the Adderall for a week and see. Right. And they might say, now I don't feel that anxiety. Or they might say, yeah, I feel just as anxious. And so, Adderall, again, for people, Adderall is a stimulant, that we use for ADHD. I think one of my biggest things in OCD treatment that I always teach people is, when I first was doing this, people would ask me, what's your special drug? Right? You're an OCD specialist. What do you do? One of the other common reasons, right? We talked earlier about people not responding because of the dose is not high enough or long enough. One of the biggest reasons I see people try on multiple SSRIs and they don't succeed is because they have undiagnosed ADHD. And what I always tell people is, remember, if people have ADHD, they often have impulsivity, right? Those are the kids that call out in class or can't wait till, they finish your sentences. If somebody's got ADHD to the point where they can't not finish your sentences, how in the world do you think they're going to resist doing a compulsion? It doesn't make any sense. And so what you'll find is sometimes people have been on multiple SSRIs and suddenly I'll start them on a stimulant. And it's not just their ADHD that gets better, their OCD gets better. They don't get, and also, right, remember, people with ADHD are disorganized in their thinking and things like that. People will often say when I start them on a stimulant, now I'm able to separate myself out from that thought. And so again, one of the big things when you're kind of doing this is not just what the treatment is. Before treatment, you need diagnosis. And when there's comorbid disorders like ADHD, they impact the treatment of things like OCD. And just, I guess lastly, just as quickly, I just should say, there used to be this thing that people would say, you can't be on a stimulant if you have OCD or tics because they will make it worse. It happens occasionally. More, not as much with OCD, but I think some people treat it as a blanket rule, and it's just not a rule. But people used to say it a lot.
Thank you. There was a comment from Gail, but thank you for mentioning like taking certain kind of like medical workups and stuff. I guess she was on a medication causing a lot of negative impacts with POX and other things, and they never took any kind of blood work. So thanks for mentioning that. At 1218 on YouTube, ROCD Healer says, can fluoxetine 60 milligrams be justified in severe resistant OCD cases?
So, I mean, again, fluoxetine is Prozac. And absolutely. I mean, so usually, again, like 60 milligrams is a decent dose of fluoxetine. And so, we typically, we will use 60 milligrams. If somebody's not responding after 4, 6, 8 weeks, right, we might move it up to 80 milligrams. I would say that, my population, generally Prozac for my patients is usually going to end up somewhere between 60 and 100 milligrams. There are some people that need 120 on one end. There's some people that only need 40, but for the most part, between kind of 60 and 100 milligrams. But yes, 60 is a good dose for it to treat OCD.
This is totally shifting gears. One of our earlier questions was at 1212. It says, this is about hoarding and OCD. Is there a good approach for treating someone whose OCD tells them that an item, so for instance, clutter, is the memory or past event instead of simply representing the memory? So often, in hoarding treatment, you'll talk to the person about, okay, you have that memory, you had that special occasion. This napkin that you took from Disney doesn't really represent that, it's more what's in you. But if somebody is really like, no, that item is my memory, and if I get rid of it, I'm going to lose my whole memory about the experience. They're asking like, what's a good way to kind of coach them through treatment?
Well, I think one thing to always remember, I think when I kind of treat people and I'm doing therapy with people, is we kind of have this trust of our brain that's unwarranted, right? That our brain does a lot of things well, and it makes a lot of mistakes, and a lot of mistakes on what risks are, what's important, right? What seems like a part of you, right? And so whether it's hoarding, where somebody, you know, has a thing that they relate to, kind of, they think it's going to change memories, or, you know, people that just think if I move this thing in my apartment, it's going to change the future, change the past, and things like that. And I think a big part of it is just kind of, this is something that your brain is telling you. And, you know, I use the example, and I use this a lot with BDD, of color blindness, right? That if somebody's colorblind and they see green and everybody else sees blue, I'm not going to talk you out of it. That's what you're seeing. But what I can kind of work with is, I know that your brain is seeing green, but if the rest of us all see blue, is there a chance that your brain is misseeing things and that maybe we can't trust it? And I think that's really important, especially for BDD, because I think it's a similar thing, but also with OCD, is that does your brain think this about this object and this thing? And is there a chance that your brain is just mistaken? It just makes perfect sense to you, right? And as we know, both, you know, us as doing therapy a lot, one of the things is people always want it to make sense to them, and then they'll do the treatment, as opposed to what really happens is they do the treatment, and as they do the treatment, now it starts making, they go, oh, now that same thing's silly to me. But again, so I think often it's taking that leap that maybe you can't trust your brain, I think is a larger OCD message.
Said. We have a question at 12:47 from Amit from YouTube. Says, what is the ERP treatment from compulsive staring, which I know sometimes gets called visually Tourettic OCD, because it's really confusing. There's some articles that say that you're supposed to deliberately stare at the private parts, because typically people with compulsive staring, their eyes kind of go there and then they freak out. So some articles say to like specifically stare at private parts intentionally, but on the other hand, some articles say instead try to make eye contact with a person instead of deliberately staring. What is that treatment in the peripheral staring for OCD?
Right. And so this is where it's important, right? When you're doing therapy, the kind of concept of doing a behavioral analysis, right? Because you don't necessarily, you know, I give people this example a lot. You know, I had a patient that was worried about accidentally downloading porn. So we'd have him read stories about people that say they accidentally downloaded and got arrested for it. And that made him really anxious. Then as he would read the articles, he was like, it's actually relaxing me now because I see that the cases are different. So something that was a compulsion, right? Something that was kind of, you know, fearful then can become a compulsion. So really I want to know what the eye contact's about, right? Like, and what makes you uncomfortable, right? Because I'm kind of going towards discomfort. So does it make you uncomfortable to stare at the private parts? Or does it make you uncomfortable not to kind of look at them, right? To keep looking at somebody in the eye. And so really, I want to know the functionality. It's always hard to give blanket things when people just describe the phenotype, right? What something looks like without knowing what the functionality of it is.
Yeah. All right. So what I'm going to try to do in the last 5 minutes is do speed round, because I just saw we got an influx of questions. The first question is from Nancy at 12:41. She says, are there any current drug studies on treating OCD with co-occurring autism? So is there specifically, if somebody has OCD and autism, is there any studies that say like certain medications are better? Or
no, you know, again, I think we don't really, again, it's hard enough, as you know, Chris, to get people to study OCD medicine, let alone co-occurring conditions and how to treat it. The thing you always have to remember with autism, I think, is a lot of people will fail SSRIs or think they failed because the dose gets too high too quick, and people with autism are more sensitive sometimes to medicine. So it's really starting low. Often they will respond to lower doses. And so sometimes even when I can't low dose an SSRI pill enough, I'll get liquid Prozac or liquid forms. That's to me the big thing if we're going to pass something along about treating autism, is that often you have to start much lower because people are more sensitive.
Carl on Facebook asked, what about, I hate these names of medications, what about trolilazole, which is soon to be
Riluzole. So we talked a little bit about riluzole before. And so riluzole is a glutamate modulating drug, and tririluzole is kind of a version of that, right? It's metabolite. And that's being researched right now. I don't know where the data is at this point in time. Big person that's involved in this is one of our main people at IOCDF, Chris Pittenger. So I'm not sure where they're at yet, but again, it works similar, really is all in glutamate modulation. So we're hoping that this is something that works really well. But again, it's still kind of, I think they're still kind of finishing up the research.
Right. Sunny Meadow asks at 12:44, caffeine consumption, should it be avoided if you have OCD?
So I don't think there's anything to say that caffeine should be avoided, right? Caffeine can sometimes make people more anxious. For some people, we know that. But as you know, and I'm sure you've dealt with this, I have some people who like drinking caffeine or coffee, but they become so afraid that it's going to make them anxious or whatever. And actually in those people, sometimes part of our exposure is, you know what, I want you to start drinking a cup of coffee a day. And so, again, caffeine, can be helpful for some people. It is a stimulant, so it can help in some ways, but it's not contraindicated in any way in OCD. It's really, again, does it make symptoms worse? If it does, okay. But again, sometimes we actually have to do exposures with it.
Yeah, I know for me, there was a lot of anxiety around OCD, and then I did drink coffee for exposures. Coffee was really bad for my OCD and anxiety, but green tea was beautiful. It gave me what I needed, which was kept me up, but I didn't have that sort of like just can't focus, making me feel crazy. So I think it's always like a case by case. ROCD Healer asked at 12:43, are there any specific foods that are preferred in OCD patients or any that should be avoided?
Absolutely not. That's my quickest answer today. But it's just there's no data to show anything that food that matters, or you shouldn't eat this or you should eat that. People do kind of end up going online and finding, oh, I'm not going to eat gluten, or there's just nothing to show that in OCD.
This question is from Andra on Facebook. She says, my 43-year-old daughter, this is 12:47, my 43-year-old daughter has OCD with co-occurring anxiety, depression, PTSD, and ADHD. She's been on Prozac since she was 12. Doctor trying to change her med, but it went bad, so put it back on it. She's seen a few therapists, but won't do homework. If she won't see another therapist or a psychologist, what should I do to help her? I'm 75 and don't know what she'll do when I'm gone.
Wow, this is a tough question for me.
I know. I was like, I just looked at the time and I'm like,
Again, I think, look, very quickly, I think sometimes if you can get the medication more on point, it can help people feel that therapy is kind of more approachable. But I also think it's important to be honest with patients on, if you don't do therapy, what's your prognosis, right? Because I think sometimes people are just hoping that a pill will solve this. So I think that's really important for doctors to say, no matter what we do with your medicine, like, you got to be in therapy at some point, or this is not going to get better.
Yeah. What I just add to this, Andra, is a lot of times when people are resistant to going back to another therapist, if I have clients that don't really do the homework, what I really focus on is, okay, can we do a higher level of care where I'm seeing you more often? So even if you're not doing the homework, at least we're working together on a consistent basis to create change. Can we make some of the treatment part of your everyday life, or even pair it up with something you enjoy? And then I tell everybody, I've gone to Mexican restaurants and had terrible Mexican food. It doesn't mean Mexican food is bad, so you have to try new things. I will say this, Andra, my mom and I run the largest family and loved one support group in the country. It meets every second Saturday of the month. We actually have one this Saturday. So if you email us, and hopefully you can put the email up, Ethan, but it's info@ocdsocal.org. Actually, I think I could comment it too, but info@ocdsocal.org. If you email us, it wouldn't let me put it up. So if you email us, we can get you on our family group list, and we'll offer you some support and some resources. But sometimes having your daughter hear OCD Stories podcast, or watching a live stream like this, I think you said daughter, hopefully you said daughter. Yeah, watching a podcast, going to support group, being around other people with OCD like myself who have gotten better, sometimes it gives them hope. The last question I'm going to ask, there was a comment about, can there be a longer video on staring OCD? If you actually go to IOCDF's YouTube, I believe there's a video with Jonathan Grayson. So type in Jonathan Grayson staring OCD. Also, if you see in the comments, Matthew Bannister has a support group for visual tourette OCD. So if you can look in the Facebook comments, maybe you can do that as well. And then the last comment really quick was Somebody asked about weight gain. What are recommendations for weight gain problems while on Lexapro? They've gained about 40 pounds. It helps them with their OCD, but they don't like to gain the weight. That's at 1251 from CNMA. So just to take us out, because I know that's a big common one.
Yeah, just really quickly, 30 to 40 pounds is not typical. So I want people to know that, right? People can gain weight on any SSRI. When they do, it's usually between 5 to 10 pounds. 30 to 40 is more what you see on atypical antipsychotics, but it can happen. So for some people, one is you might just try switching the SSRI, right? Just because somebody has weight gain on one, they might not on another. Fluoxetine, probably from a data standpoint, which is Prozac, is the least likely to have kind of weight gain, but you can still gain weight on that. We treat weight gain sometimes different ways. We use a drug called metformin, which we use in diabetes sometimes to treat medicine-induced weight gain. Sometimes we use a drug called topiramate, also called Topamax, for weight gain. But again, I think so there's a question of, again, is it worth switching and trying something else, or again, do you treat it? And then sometimes that depends on how good the response is.
Well said. I just put for Amit, I just found there is a video on the IOCDF YouTube that is an hour with Dr. Liz McInvale and Dr. Jonathan Grayson about compulsive staring. So please watch that. It's under youtube.com/IOCDF. You can just type in searching staring OCD. It was about 4 years ago. I put the link. Emilio's putting the link in the chat. Woo, we got through all the questions. We didn't get through any of the pre-submitted. So people who pre-submitted, I'm so sorry. We had a robust group of live people today. I wanted to get all of them. So we got to every question. If I missed your question, I'm so sorry. Like I said, we're back every Wednesday at 12 Eastern. I was pretty good with the chat. So if I completely missed your question, please come next week and put it in the chat, and I'll make sure to get to that. But I want to give a huge thank you to Dr. Stephen Poskar, who came out, answered a lot of questions, gave you a lot of good information. Please send this to anyone who could find it educational and watch it back. There was a lot of really good information, and you might not always get this kind of robust information and conversation with a psychiatrist if you can't find a specialist in your area. Stephen Poskar, thank you so much. We will definitely have you back. We're here every second Wednesday with psychiatrists to talk medication. Thank you for being here, and thanks for answering our questions. For everyone, don't forget there is the IOCDF conference that you can now register. It's in July in Chicago, but go to IOCDF.org for all your OCD related stuff. And will I be seeing you at the conference?
You will. And just last, I guess I didn't mention it, so just for people maybe that are listening, we treat people right now in New York, Connecticut, Florida, and Virginia. Ooh. So again, we do consults, and again, I do clinics. So if anybody is in those areas, we're available.
Where can they find you? What's the best place to go for your website?
Probably the best thing to do is just go to www.ocdnyc.com.
I love that. OCDNYCD.com.
Actually, on that page, on the first page, there is a whole video lecture on medicine for OCD that I did at Columbia years ago. So that's often a good resource for people.
All right, perfect. Make sure to check out OCDNYC.com, also IOCDF.org, and we hope to see many of you at the conference. Don't forget, it's hybrid this year, so if you can't join us in person, you can definitely get all the fun virtually. Take care, everyone. We'll see you back next week. And one more shout out to Dr. Poskar for joining us this Wednesday. Take care. Remember, OCD is treatable. Please get help. Thank you for being here.